temporary pacers that you guys have on the unit as well. So I was asking Hannah to come and kind of talk with you guys about just the temporary pacers. I'm going to go over like single chambers and dual chambers and kind of how they function, where those leads sit, and how they react to the device. Is there anything offhand that you guys would like me to cover more? I just don't want to get off track with things that are not as important. Are there any scenarios or
That's what I was gonna ask.
functionality?
Are you gonna go over some of those
Yeah.
kind of things?
Yep.
Okay.
Because we'll get some, like this happened probably a couple months ago for me. It was, they came in with pads on being paced and they went for a temporary pacer and they were like, he's only being atrial paced with he only had one course, so it was clearly being atrial paced, but we were trying to troubleshoot it because it didn't look like it was firing correctly, so
Okay.
just going over that stuff would be
Sure. Yeah, exactly. So I've got strips of what capture looks like versus non-capture. We're going to go over sensitivity and how to make those adjustments. If you don't see pacer spikes, then kind of tells us we're not seeing what we need to see on the strip. So we'll go over all of that, and then just stop me if you're like, okay, wait, let me figure this out, because in the first one it's hard. These concepts are very kind of backwards to really understand and to get. So we'll talk through those and we'll just take it at our own pace. So this is for you guys. But so what we'll talk about is just the type of pacers. So like I said, single, dual, programming considerations as far as indications, underlying rhythms. Don't really go over types of pacemakers. The MBG code, so what each mode, whatever your patient's programmed to, what each letter stands for in that code. And then timing cycles, we're gonna briefly touch on this just to make sense of why or what to expect when you see a pacing spike versus not, and how the device is programmed based off the timing cycles and basically when to expect what to see. So upright behavior, we'll talk a little bit about that. That's just usually if the atrial rate gets a little bit higher and the device isn't able to track one-to-one anymore. And then thresholds and sensing. So that'll be a concept we'll kind of get a little heavier on so that we know how to ensure that we have capture, how to program that appropriately, and then how to run a sensing threshold as well. So let's get into it. Okay. So whenever you go to program a pacer, I'm not thinking about that now. You'll want to always kind of start and know what their underlying condition is. Are they heart block and just not coming in? They're barely hanging on in the 20s. We're going to expect to see pacing a lot and a lot of captured beats. AV block, sinus node dysfunction, things like that. Avoidance of RV pacing is kind of more with permanent pacemakers. We don't want to pace, initially getting out of surgery, pacing all the time is totally appropriate because we want to improve that cardiac output, blood pressure, things like that. But long-term RV pacing can be bad and can send a patient into cardiomyopathy and increased risk of AFib. So those are things that we try to program and troubleshoot around. If the patient isn't dependent on their pacemaker, then we try to back off on how much we deliver pace beats. AV synchrony, that's just making sure that the A and the V are talking appropriately and in the right time. Battery life is more of a permanent pacemaker consideration. So this is a permanent pacemaker, but the concepts of the leads are very similar to what you guys see. So here, if you have a single chamber, that's typically going to be a lead all the way down into the right ventricle in the apex, and you'll just that sits there. And then the dual chamber, they don't typically put in single chamber atrial leads. Not that they never have, but that's not very standard. But if you've got a lead in the atrium, it's going to sit like this. So typically that'll be a dual system. And permanent pacemakers or epicardial leads is when you'll run into this type of wire. So this one is in the CS and goes all the way out into the left ventricle. And this is around the same area that an epicardial lead will be placed as well. So they act as a function of getting these ventricles to pump and work together. That's essentially what epicardial and RV leads do. For patients in cardiomyopathy, really wide QRSs. Okay, so pacemaker is programmed to function. We look at which chamber we want to pace. Which chamber do we see the patient's own intrinsic beats coming through? and how does the pacemaker behave when it sees those beats or does not see those beats. And that's where we get our MBG code from. So this diagram here is a way of breaking down the mode that it's programmed into, and that's obviously called the MBG code. But this first letter, so this is VVI, first letter will always indicate what chamber is being paced. So in this one, it will be the ventricle. If you see an A, it'll be the atrial. If you see a D, that will be dual, so that can be both. This one is, the second one is the sensed. So it just looks on the sensing in the ventricle in this case. And then this is how the pacemaker will respond to it. So if it sees an intrinsic or senses an intrinsic ventricular beat come through, then it's going to inhibit a pace beat from being delivered. If it doesn't see it in the appropriate amount of timing, the lower rate, or like 60 beats a minute, then it will deliver a paced beat. So it's all about what it's sensing and what it's seeing and how it's going to deliver a paced beat. Okay, so this is just even further kind of what I broke down with the letters. So the pace, sense, and then the response. So these are all of the possible modes that it can be programmed to. The typical ones are VVI, AAI, DDD, and then I would say either like VOO or DOO, and those are asynchronous paces. So the O represents there's no sensing that's going to happen. It's just going to simply pace without seeing anything. And on the temporary pacers, yeah, there's actually an emergency DOO setting. I'm not sure if you guys have noticed that before, but it's up here on the right-hand corner.
What is that for?
So this is for if you see a patient that's losing capture and you're not really sure why, and it's pretty serious that they get pacing back, you can always hit this, and it's going to program the device to the max amount of output that will be delivered. So it's going to pace at 80 beats a minute. It's going to deliver all the max output to try to get some kind of stimulation and paced beat from there. So if you're in doubt and you're like, oh my gosh, is this, if you don't have time to troubleshoot yet, or the patient's tanking and you're not really sure why, but you know that it's something potentially with the leads, then just go ahead and put them in an asynchronous mode. And then you can, try to troubleshoot and walk it down after that. But that's always oh gosh, I don't know why, but I'm going to pace both chambers just because I can. So that's a good mode to have in your back pocket.
I was always like, what does doom mean? When they're doomed.
Okay, so we already went over, these are the common modes that they'll typically be programmed to. So we'll go through and talk about each of these strips and what we expect to see. So like we said, the OO mode is just going to deliver paced beats at a set rate, which we'll say is 60 beats a minute in this case. So you can see here, there's a paced beat lined up right before the ventricle, and then we see a wider QRS to follow. So that's a captured ventricular beat, as is this one. So we go to this one, and we actually see that falling behind, but that just tells us that it's not sensing anything, it's just marching through at the programmed rate that it's set to. So we kind of see some irregular beats coming through, and they're not capturing because these are in repolarization, so you're not going to get any beats to capture if you're like in the T wave, and you don't want to be in the T wave. But this is typically, if you're in this mode, you want to make sure that you're at least 10 beats a minute above whatever their intrinsic is, so you don't have these competitive beats coming through, because that's when you run into shocking on a T wave, potentially. You've got to make sure that you're overdriving that rate, and you see these beats marching through the whole time without these intrinsics.
Even with it not sensing, it'll still, because you have it going.
Yep,
That makes
it just
sense.
marches out. Yep. So like say they're coming in on their own around 60s and 70s, I would make sure to program them at least 80 or 90, just to make sure you're 10 above that. So
Okay.
you want to be in the driver's seat when you're in an asynchronous mode. So that's the biggest thing I would say to remember, so you don't run into that scenario.
Because we've seen that.
Yeah. Pacing on T's.
Yeah.
Yeah. Makes you want to kind of.
They actually went into, it throws them into VFib, right?
Yep. Sure does.
I was wondering why we didn't hook the pacer back up. We just coded them.
Was it this guy on Friday?
No, it was a patient with Kelly. It was a while ago. was in
Did-
10.
Did it happen?
But I
on
just
Friday?
wondered about that, it was something I was
Yeah.
gonna ask, but.
Yeah, no, that's a good question. So in that case, I would suggest increasing your rate.
Cause that's essentially what you do anyway, shock them.
You're gonna shock them again, yeah, but you, in this case, like, are you saying to like get them back out of it, but
Yeah, wouldn't that help get them back out of that though?
you can't count on that to happen again as far as a paced one goes. That's
Oh,
a
maybe
very,
that's why.
that's a very, I would say rare thing that happens. Like we don't really encounter a whole lot of pace on tees to where it sends them in BFib. I've seen it, but it's not like, I think somebody said the other day they had seen maybe a dozen over their career. They've been an EP forever, so it's super rare, but I have seen one here happen, as a matter of fact. So, yeah, it can't not happen, and that's probably everybody's biggest fear. So, okay, and then in this scenario, we've got VBI pacing. So in this case, we see, say the program delivery rate again is 60. So we've got a nice paced beat here, wired QRS. We know we're capturing, and then we see an intrinsic come through. So that just says that the device was able to sense the R wave appropriately, and it was within that 60 beat a minute window, so it's not going to deliver a paced beat. If it's outside of that, or say they're in the 50s, that's when you're going to see a paced beat every time. So it's acting appropriately and withholding pacing, as long as it's coming through at a higher rate. Okay. And then we've got AAI, so that is just looking, we're only going to be able to pace in the atrium. We cannot, if a patient is in heart block, this is not one that you want to choose. I would say like coming out of surgery, things like that. This is one that you won't have any ventricular backup support, so you're just going to see your rate drop. So in this case, we see this is paced, right? And then right after that is followed by a P wave and then an intrinsic ventricular beat. And then this one's not paced, so that says it withheld because it's coming in at a faster rate and not below 60. And then this one timed out, so then we delivered a pace beat to the atrium and then an intrinsic beat, and it follows like that. So that's just another example. Okay, DDD gets really fun. So DDD can, depending on what the patient's doing, say they're having kind of an irregular rhythm, you're going to see some different pace beats. They call these like the 4 phases of DDD pacing, because you can be atrial sensed, atrial paced, ventricular sense, and like vice versa with all of them. So in this case, I think we've got a good example of these coming through. So here, I don't think there's a pace beat, but this would be like an intrinsic. So you got an intrinsic P wave, intrinsic R wave, and then we've got no pacer spike, so that's an intrinsic P wave, and then a paced R wave. So this would be A sensed, B paced. This one would be A sensed, B sensed. This one is A paced and B paced, because you're capturing both in the atrium and ventricle. And then this one's A paced, B sensed, and then A sensed, B sensed. Does all of that make sense, how it's kind of marching through? So at just a glance, it looks pretty like, what is going on? Like there's pacing spikes all over. But if you look at them and see if a captured beat is following and they're lining up appropriately, then that's normal device function. So, but DDD pacing has a little bit more variability than just being able to look at, an AAI pace versus a VBI, because then you're only looking at one chamber versus looking at 2 at the same time here.
So why would it pace the atrium and then also pace the ventricle? Does that mean that the ventricle wasn't going to squeeze?
It means that it was not falling, and this is where we're going to get into those timing cycles. So there is a timing cycle that's that we can program called an AV delay. And an AV delay is a certain amount of timing, which is nominally like around 150, 180 milliseconds. So if an atrial paced event is sensed or paced, and then in this amount of time, if it goes over the 150 milliseconds and they don't see an R wave come in, then it's going to deliver a paced ventricular beat. So you've got kind of your lower rate that you can look at for like R wave to R wave to R wave, but then your AV is always going to be that very small delay from your P to your R wave. And if it's over that, that's when the pace is delivered. So that's a good question. Does that make sense?
Yeah, it's kind
Kinda.
of preventing it from going into first degree heart block.
Yeah, exactly. So if it's gonna fall outside of that, cause yeah, we don't want a long, over, like we were talking earlier, 300 millisecond or, so we've got a program or a feature that's like, okay, we're not gonna allow this much of an AV delay, because that's not physiologic. So we're gonna deliver a pace speed to keep up with the rate that way, so.
Some of them don't have a underlining rate at all, which you'll see that
Mhm.
on the duals with the open hearts.
And they'll just pace the whole time.
Pace along like both.
Yep, cause they're both just really slow, or they're stunned, and the sinus is too slow, the ventricle's too slow, and they're just not, so they need that pace speed to keep up their rate, so. Okay, so yeah, that is getting into the next one with timing cycles, so we'll just, briefly go over that, just to make this, terminology just familiar to you. So the lower rate is the lowest rate the device will allow the heart to beat. So typically we program them to a 50 or 60 beats per minute. So the lower rate, if you say you're VVI paced and you're just pacing along, the pace beat you'll be able to measure out every 60 beats a minute. You'll see that pacer spike, so it's like 5 boxes. You'll see that march out every single time. Now, if a sensed event comes in before that, then that's when that paced feed is withheld. So you're not going to see that because it's coming in, maybe in the 70s in that case. So, so that's your lower rate. Anytime it falls below, it's always going to deliver a pace. Max tracking rate is the upper rate limit. Have you guys ran into having a really fast upper rate, so like a high atrial rate that's not conducting to the V appropriately? Sometimes it'll be like a sinus tack. They'll be up in like maybe over 130. So we typically program devices 120, 130. If it gets over that 130 mark, you're gonna start seeing some upper rate behavior. So you're gonna see some blocks. You're gonna see like a 2-to-1 type pattern.
You guys actually set the pacer at a rate of 130.
We set it to an upper. So that's just the max rate that the device can achieve without going into a Winky Bach or 2-to-1, because we don't want to track that high. Yeah, we don't want to track any higher than that. So
Wow.
the lower one, yes, we will pace if it falls lower, and then if it exceeds the upper one, that's when we won't deliver pace speeds, because we don't want to keep a patient's heart rate up, in the 150s, 160s. Sometimes you'll see that with younger or pediatric patients. That's a different story. But in this case, yeah, docs don't like them to be sitting there not doing anything and deliver it at 150 beats a minute.
Probably because most of the time we see them, they're open hearts, and they never want them to be
Yeah,
in the high.
Yeah.
or they have bradycardia or a heart block and they're getting these and they need to be at a rate of 80.
So you would
We
only
typically
really know
don't.
that whenever you think their underlining rhythm is like 120s, you want to pace above that, you would do like 130s?
So we are not, so the upper tracking rate is just sent as almost like a cap or a roof. It's not meant to pace them at that rate.
Oh, okay.
Yeah, it's meant to be a preventative measure, so if it goes over that, the device will not go track 1-to-1 for that.
Okay.
Yeah, so it's not like programming the device to go at 120. It's just saying that up until 120, it'll go like an A pace, B pace, A pace, B pace. But if it goes above that, say, 140, you're not gonna see that. You're gonna start seeing like a Winky Bach behavior, because the device is saying, nope, I'm out. Like,
So what do you do for somebody in that case?
so that could be like an ATAC or an AFib, and we don't want to track those rates. So we will
Medication? based?
medication. Yep, absolutely. And that's a lot of times I put in some devices with Dr. Klein, and we're sitting right at that because they've been in heart block and their atrium's just freaking out, ready to deliver cardiac output. So their rates will be super high. He's like, okay, I'm gonna get them on some meds and try to get more rate controlled
Okay.
in that case. So yeah, medications are your friend to try to get that down, so you're not
That
tracking
makes
that.
sense.
But in permanent pacemakers, we've got a mode that can switch them out of that, so it's not tracking that, and it'll just back the pace of the ventricle. So, okay, let's see. So here kind of an example of pacemaker winky back. So when it goes just above like that 130 we were talking, you're gonna start to see that like the device, and you know, I don't know if you usually see this with temporaries, but you could. So the pacemaker is marching along here. It's starting to get up 130s like we said. So we've got paced, 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 and then you almost see a block here. Well, this atrium is going too fast, and this is gonna fall into what we call a blanking period, or PVAR. So the device is meant to blank that out so that it stops tracking at those higher rates. So you're gonna see kind of a pattern of like a, 3 paced beats, kind of a delay, another 3, and a delay. So that's a natural pacemaker winky back there. And that's okay, but you would want to either call the EP or the cardiologist, or have one of us come in, because we can program the device at kind of a deeper level to extend that PVAR or extend that timing cycle to either allow it to come in or not. Or rate control will be your friend. So, and then if it goes even higher than 140 in this case, then you'll start to see a 2-to-1 block, and this is when a patient's heart rate will be cut in half. So, because the device is like, I can't track that, and so every other atrial beat will fall into a blanked period or a refractory period, and is not tracked 1-to-1 to the ventricle. So we'll sometimes do this in like stress testing or echo lab. We'll get them on the treadmill, and we'll see if they're able to get their heart rate up into the 140s. And they've actually seen patients like they'll almost slump over because their heart rate will go from 140 all the way down to like 60, just like that. So that can cause them to pass out and things like that. But I don't necessarily expect you guys to see this as much, but something that if you see a very odd sudden pattern where it looks like you're blocking, or like that abruptness, then you got to think, okay, well, what's my atrium going at, or what's my how fast are we going, and can the device keep up with that?
So is that like an AFib then, or are you talking more of like your blockages?
I would say with younger patients we'll see this, like maybe in their 40s, that their rates can get up higher, and if their device is programmed at say 120, and they go to exercise or work out and they get up into the 140s, they're gonna see this, because if they're dependent on their pacemaker and they count on that 1-to-1 tracked beat, once it gets past the 130 mark, that's when it's cut in half.
Okay.
Yeah, because the pacemaker is going to say, no, this is too fast. I'm not supposed to track this high. So then that's when it will back off, which in this case, it isn't good for the patient, but it's also something that we don't want to track high atrial rates either. We can't live with that fast of a rate all the time. So, okay, so this next one, if I can just add this without XVA. I learned that last time. So we're gonna watch like a quick, I think it's like an 8-minute video, but it covers a whole lot, and it's about capture threshold and sensing threshold. So I'm gonna put that up here.
We'll demonstrate how.
And disclaimer, this is a single chamber device, so it'll just, it's just gonna go through how to evaluate sensitivity and capture, and I'll show some running strips with it too, so I think it'll be really helpful.
On the sensing threshold. But first, let's review the functionality of the dials and buttons on the 53401 single chamber temporary pacemaker. The on-off button is located here. This is the lock-unlock button. Pacing rate is adjusted using this dial. This is the dial to adjust the pacing output in milliamps. This is the dial to adjust sensitivity in millivolts. These are the controls for rapid atrial pacing. This is the battery indicator.
Have you guys done any rapid
This is the
atrial
lock
pacing?
indicator.
I was gonna ask you about that, cause
This is the green light, which indicates pacing when flashing.
Single, how do you do that?
This is the
Yeah.
blue light,
Okay.
which
That's gotta be
indicates
the
sensing
yeah,
when
I was
flashing.
for like a flutter,
Okay.
atrial flutter.
First, we'll review the basics of
Forming
sensing.
cardioversion.
For the pacemaker to pace at the appropriate time, it needs to sense the patient's intrinsic rhythm adequately. Sensing is like a fence. The higher the number, the less sensitive. The lower the number, the more sensitive it is. When a fence is set low, more is seen on the other side of the fence. The higher the fence, the less is seen. This is true for sensing. With lower numbers, more will be seen. With higher numbers, less is sensed. Appropriate sensing results in every heartbeat being properly sensed. This means that when the lead or wire is located in the atrium, all P waves are sensed. And when the lead or wire is located in the ventricle, all R waves are sensed. It also means nothing extra is sensed, such as a T wave, which would be interpreted as a heartbeat. To perform the sensing threshold test, first turn on the temporary pacemaker without connecting it to the patient lead system. Ensure the patient is connected to an ECG you can monitor during the testing. When the temporary pacemaker is initially turned on, it will begin sensing and pacing in AAI or VVI mode with nominal values of a rate of 80 ppm, output of 10 milliamps, and sensitivity at 2 millivolts. In this example, we will determine the ventricular sensing threshold in a patient who has an underlying rhythm of 50 beats per minute. The temporary pacing lead or wires are in the ventricle. Recall the definition of the sensing threshold is the least sensitive setting at which the pacemaker can detect a heartbeat. The sensitivity setting allows you to control the pacing mode between synchronous or demand pacing and asynchronous pacing, also referred to as AOO, VOO. Notice the range on the sensitivity dial goes from the most sensitive setting of 0.4 millivolts to a setting labeled async. When set to async, the sensitivity is set to a value so high that no underlying intrinsic signal can be detected. Therefore, to pace asynchronously, set the sensitivity dial to async. To pace VVI or AAI, the sensitivity setting must be set so the device detects the underlying rhythm. Set the rate to at least 10 ppm under the patient's intrinsic rate. So in this example, we will set the rate to 40 ppm. To reduce the risk of competitive pacing, decrease the output to the minimum value of 0.1 milliamp. Plug the pacing cable into the socket located on the connector block on top of the temporary pacemaker. Verify that the cable end clicks when it is inserted into the temporary pacemaker connection. The audible click signifies that the plug is completely inserted into the receptacle. Note the sense indicator is flashing, which means the device is detecting the R wave. In other words, the R wave is at least 2 millivolts. Monitor the patient's ECG to ensure the sense indicator matches the device lights. Slowly turn the sensitivity dial clockwise, which increases the millivolt value until the sense indicator stops flashing. The pace indicator flashes continuously, but capture is not likely because the output value is set to the minimum. Next, increase the sensitivity by slowly turning the dial counterclockwise, which decreases the millivolt value until the sense indicator starts flashing. The pace indicator then stops flashing. This is the ventricular sensing threshold. Set the sensitivity dial to half or less of the threshold value. This setting provides at least a 2 to 1 safety margin for sensing. The same process can be completed for an atrial sensing threshold, assuming that the pacing lead or wire is in the atrium. Let's discuss oversensing and undersensing based on the sensitivity settings. Oversensing results in underpacing. Let's say the sensitivity is set at 2 millivolts and the device is sensing both the R wave and the T wave. This will result in a pacing rate less than 60 paces per minute because the device resets the timer based on the last sensed event, and the T wave is being counted as an event even though it does not represent QRS. Let's say the patient's R wave is 6 millivolts, but the sensitivity is set at 7 millivolts. A higher sensitivity number makes the device less sensitive, meaning it is less likely to see an R wave. In this case, the device will never see the 6 millivolt R waves, only R waves greater than 7 millivolts. Therefore, the device behavior is similar to VOO mode, pacing asynchronously. In this video, we'll review how to perform pacing stimulation thresholds on the 53401 temporary pacemaker. The 53401 may provide either atrial or ventricular pacing. A stimulation threshold test is performed to determine how much energy is needed to consistently provide pacing. When there is consistent tissue depolarization, it is considered the stimulation threshold. A threshold test should be performed as part of the preparation for use when using the 53401 temporary pacemaker on a patient. The sensing threshold test should be performed first. Once the device is connected to the patient, verify you have proper sensing by checking the cardiac monitor and the device. Now we are ready to perform a ventricular threshold test. This patient has an underlying rhythm. Remember, throughout this testing, you'll want to watch the ECG monitor and the device. First, increase the rate to at least 10 paces per minute above the patient's intrinsic rate. Next, turn the output to 10 milliamps. Verify that you see a rhythm consistent with pacing on the cardiac monitor, as well as the pace indicator on the device. Slowly decrease the milliamps by turning the output dial counterclockwise until the ECG shows loss of capture. Watch the pace and sense indicators to see if the device is sensing and pacing consistent with the ECG monitor. Next, slowly increase the milliamps until the ECG shows consistent capture. The pace indicator will flash continuously and the sense indicator will stop flashing. This is the stimulation or pacing threshold. Set the pacing output to a value at least 2 to 3 times greater than the pacing threshold value. Since the threshold is 1 milliamp, set the output at 2 to 3 milliamps.
You're like, what? Okay, so, let's look at some strips together and kind of go over what they were talking about. Any questions, first of all, off of that? Or you just want to get into kind of like reviewing all the strips? So when we're talking, okay, so capture threshold, that's the one that we just talked about. So two different concepts when you're running thresholds, sensitivity versus capture. Capture is the energy required to be able to depolarize that tissue. You have to have enough energy to create a stimulus or a paced ventricular beat after that. If you're not, like in this example, like you see a paced beat, but there's nothing following it, and you see that there's way too much time here to go without a ventricular beat, then you're thinking, okay, I might want to up my MA or my output on the device. So you'll want to turn that up, and it might even be good to run a threshold test as long as they have a decent rate underlying. So in that case, you would just want to, and ventricular pacemaker is set at 60. So I would even overdrive it a little bit higher, like say they're sitting in the 50s. I would probably run my threshold test at like 80, and then start it up at like 10 milliamps, and then walk it down, see where you lose, and say you lose at 2, then you'll want to program a 2-time safety margin, because you don't want to set on the fence right where you had capture. You want to give that plenty of a buffer to know that you're going to be capturing all the time, because it could increase and go up to maybe 2.5, or thresholds can change slightly. So let's see. Okay, so looking at this strip, we're going to determine where we're losing capture at. And these volts are kind of what we see on permanent pacemakers, but either way, on the dial, you'll see it walk down the same way in volts. So here, we're at 1.25, we see some nice captured ventricular beats. You see a pace, QRS, so you're overdriving that rate. And another way to check is whatever rate you've got it at, make sure that's what your monitor says. And we talked even earlier about, if you're not sure about it, have a second pair of eyes so that somebody, if you're looking at the dial and watching that to see if it's paced, somebody else can be making sure that, to see if you lose capture or not. So in this case, it looks like we lose here, and we see kind of an intrinsic come through. So you see loss of capture. So in this case, the threshold is sitting right around 1, but we always bump it up to another quarter volt. So we make it 1.25 is our threshold. Now, after that, you'll want to add on that 2 times safety margin. So 1.25 you would then want to program the device to 2.5. Does that make sense to give it enough of that margin there? Okay. And then on to sensing. So these are kind of the signals that we'll see, say that these are, potentially P waves, R waves. It's just the millivolts on how well you're going to see that signal. So you want to make sure that when you program sensitivity, whether it's on the A or the R, is that your sensitivity or your fence is going to be able to capture this or be able to see that beat come through. If your fence is all the way up here, say it's at 3, you're never going to see those R waves come through. So that's when you would want to walk it down and have at least a half of a margin. So those are 2. I would even leave a sensitivity at maybe 1 in this case. And then 0.5, those are pretty small P waves. Just make sure that you're not at 1. You want to bring it down to maybe 0.25 in that case. Okay, does that make sense with the fence and stuff? It works kind of backwards because you want to go like higher with your fence and higher with your value as far as sensing goes. But it makes it, the higher the fence, the less sensitive or the less it's going to see from the intrinsic beat that comes through. So we'll look at that here. So the less sensitive, the higher the number or the higher the fence. So if you see that 5, you got your fence all the way up there, any R waves that are coming through and you're trying to sense, you're not going to see anything. It's too high. So you've got to bring that fence down so you can just get at least half of that signal in there. And then you're going, if you want your device more sensitive, you're going to have a lower number. So that's a lower fence. But you've got to be careful not to lower it too much because then you're going to allow T waves to come through. So we want to make sure that, especially when we're trying to get a sensitivity on a R wave, that we just see at least half of that R wave, but covering up the T wave, or that'll double count. So, and then it will inhibit beats from happening, or pace beats from happening. So there's a kind of a balancing act you got to do, and you can always run that sensitivity test. 2 is pretty nominal, I would say, to be able to see R waves come through. Usually R waves are at least 2, but if you're expected to see intrinsic beats coming through and they're not, then it's like, okay, we got to take it back to the drawing board and do a sensitivity test. So you drop that lower rate down, and you look for those sense beats to come through, and then you can increase it from there until you start seeing the pacing light start to flash. Then you're like, okay, this isn't sensing anything anymore, and that's why it's delivering a pace beat. So you've got to walk it back down.
And you would always want to go until you see the pace, or otherwise you could be sensing your T.
Yes.
What about the P wave? Because it's smaller than the T wave.
Yeah, and that'll definitely have a lower sensitivity. So if you're having really fine P waves and you do have your device programmed AAI, and you feel like you're under sensing, then yeah, you'll want to run a sensitivity test to be able to see that. But you can usually leave that down to like 0.5. P waves are usually, I would say, measured right around 1. So 0.5 is a good place to start, and then 2 is a good place to start for R waves if you're just going off of a nominal recommendation for what to see. But yeah, there's really small P waves and there's really small R waves, so this is something to have in your pocket to know how to
I
handle
don't know
those.
if you were referring referring to like on the dual chamber, there's two separate settings. So like your A setting will be 0.5 and your B setting would be like 2.
Okay.
So you'll set those separately on the dual chambers.
Yep, exactly. Okay, so under sensing and over pacing. This is where the device is not sensing appropriately, so your fence is too high. So it's going to deliver a paced beat because it's not seeing any intrinsic activity come through. So this is when you'd want to lower your fence, lower your sensitivity value to be able to see those R waves come through. Because you'll just see here, you'll get random spikes in places that they shouldn't be. It's because they don't see that R wave coming through. So in this case, you see that pace kind of on T. You'll see another, this is an intrinsic that came through, but it's not sensed. This is actually a good captured beat there, and it's capturing, but the problem you'll get into, it starts acting in an asynchronous mode, so it's gonna deliver that paced beat inappropriately, and it could deliver it on an intrinsic T wave. So that's what you gotta be careful of, when you look at that. So yeah, back to, if you're like, okay, why, this is obviously not seeing anything, I need to adjust my sensitivity so it can see my R waves, and we're not pacing on T, okay? Any questions about that? Kind of just wrapping your brain like, okay, under sensing, not seeing it, gonna over pace because it doesn't see anything coming through. Over sensing, under pacing, so it's actually seeing more of a signal because your fence is too low, so it's thinking that any signal that it sees coming through, that it's an intrinsic signal, it doesn't need to deliver a pace. Well, that could be T waves, that could be myopotentials, which is just electrical activity going on in the heart. Your EKG kind of looks squiggly sometimes. So it'll say, okay, well, I'm seeing plenty, I don't need to deliver pace. Well, you've got long pauses there, and you're like, why is this not pacing at, say a rate of 60 in this case, and you're seeing like maybe 40 beats a minute? Then it's like, okay, well, we're obviously seeing too much, and it thinks it's, acting appropriately. We've got to raise that fence back up to make it a little harder to see, so it's going to deliver paces adequately. Okay, so you've got, pace beat here, capture. You've got an intrinsic there, but then you see it goes all the way out to here. I don't even know, it might be 30 beats a minute, and it should have delivered some kind of pace beat here, but it's saying, oh, I think there's something there. So yeah, you don't want to. Oh, and actually, if you cheat and look at your marker channels, which I don't think you guys can do, but you'll see a bunch of these come up, and it's like, wait a second, that's a V-sense, that's a V-sense, that's a V-sense. It thinks those are all ventricular beats, and it's like, no, it's just this one. So the device is like, oh, everything's coming through just fine. So does that make sense? Okay. Sorry, I keep asking. I don't want to keep talking and get ahead of if you guys need to let something marinate. Okay. So recap. Which of these pacemakers is programmed to a more sensitive setting? So think about your fence. The lower the fence, the more sensitive. Higher the fence, the least sensitive. So which one would be more sensitive?
A.
Yep, because it has that lower value. Oh, I didn't even realize it had that in there. I just had the. Okay, so these are resources that I've probably said way too many times to Hannah today. This Medtronic Academy. These are ones you have to get on at home because it'll block you here from getting on. But it walks through all of the each of the pacemakers we have, the dual chamber or the single chamber, and it actually has tutorials, even that sensing and threshold tutorials on there, which I think is super helpful. And then it also walks through more of a deeper dive on those dual chamber modes if you ever need to mess with timing cycles or mode changes or to understand why those are helpful. I've got, okay, maybe just a couple more minutes. We'll run through just a few more like examples or scenarios, I guess. Okay.
Is there any way we could get a copy of the PowerPoint?
Yeah, I'm gonna find some. I said I'm like, this one's like homemade, one of them is, so it's like very non-official Medtronic. But I will get some kind of PowerPoint together, and just send it to you. So we've talked about the MBG code. Does anybody have any questions about where those, letters stand and why? Does that make sense? Okay. So here is one scenario. The stimuli delivered by the pacemaker does not initiate depolarization of the ventricle. So we see here, we've got two really nice captured beats, and then we see just a pacing spike with nothing to follow. It didn't stimulate anything. So what do you think you'd want to do in this situation? With a pacer spike and nothing to follow it, you have any idea what we might
Is this
do?
when it's in like the AOO or the VOO and you switch out of it?
This would probably be like a VVI mode. So it's going to allow that intrinsic to come through, but if it doesn't come through in the right amount of timing, it's going to deliver a pace beat to the ventricle.
So is it oversensing?
Not oversensing, not a sensing issue per se, because we do see a pace spike, so but nothing to follow it.
So increase the output.
Increase the output. Yep. So we want to see, whenever we see a pacing spike, and it should follow, like we see here, these are capturing really well. We got a nice wide QRS, and then we see one here that's got nothing. We're kind of like, that should have captured something, or had something to follow it, as long as it's not like in the middle of the QRS. So yep, increase the output. And if that still doesn't work, then one thing we talked about earlier is, evaluate your EKG, make sure everything is marching out right and appropriately. But if you're up at like max output, nothing's happening, maybe even a DOO, like asynchronous, and it's still not capturing, I would suggest ordering a chest x-ray to evaluate where that epicardial lead might actually be. Well, in this case, epicardial leads are pretty intact. I would say like a regular pacing lead. Epicardial leads aren't usually. You will see epicardial lead outputs increase over time though. It takes a little bit more energy. For some reason, it just goes up on them. So yep, you would want to increase your rate at least 10 above to overdrive it, and then increase your output, and then walk it down until you see it lose capture, and then put a 2-time safety margin on it. Okay, so pacemaker fails to emit a stimuli at the programmed interval. So we see these pace beats here, and then we see an intrinsic one come through, and then way too long of a delay. So we don't see a pacer spike, so I don't think output. We don't see anything, but that's way too slow of a rate if we're programmed there. So what do you think the device might interpret that as, or why they would think it was okay?
It's oversensing.
Oversensing, underpacing. Yep, you got it. And then, let's see, failure of the pacemaker to sense an intrinsic R wave. So that's kind of where we
Sensing too
plot
much.
back to. Yep. It is actually, let's see. Yes, increase our sensitivity. I have to even check what I say because this gets very backwards. So increase your sensitivity. So that means that the device is seeing too much and it's delivering these pace beats just whenever. So we will increase the sensitivity so that it is able to better see that those beats come through appropriately. And that is it for our timing purposes too. I could talk about this stuff all day, but do you guys have any questions about the functionality of this? This is a dual chamber that I have today. Do you still plug in like your colors appropriately to there, or do you just label them and plug them in for like the temporary cables?
I've seen them with like matching colors.
They match them, okay. I wasn't sure if people still did that or not, or, and then any questions about like mode changes or, features that everybody know, like battery unlock and changing battery out? So battery, it's this little button right here, and it just pops out. and it takes 2 AA's. I wanna say that so you can change the batteries out if the red light is flashing on a patient. You can change these batteries out, but I wanna say you maybe have 30 seconds to do that. So it's like, kind of like a must. If you must do it, just have your batteries right there and then do it pretty quickly, especially if they're dependent. So yeah, you can change
Does
them
it
out.
go back to the normal settings? when you
Yes.
put that back
Yeah,
in?
it's
So you
just-
have to okay.
Yeah, it's in like a kind of a standby mode, but it will still, it's like a pause almost. So it'll pause whatever settings, still deliver therapy while you change this out. So you just can't, mosey and take your time, but I think 30 seconds is usually pretty sufficient to do that, so.
If you're ever that concerned about it, you can always grab a second
And
box
reprogram it.
and program it appropriately, and then just switch your wires.
Absolutely.
Yeah, I think I like that one better.
I like playing Russian roulette. Just kidding.
Dicey. Yep.
I like drop the battery.
I'll be like,
It rolls into